Good morning, ladies and gentlemen. I'm not Charlotte Coles, but Dr. Charlotte Coles is the current chair of our group in the UK on neoadjuvant radiotherapy, and I've kindly borrowed a couple of her slides from a presentation we gave a few months ago. And this work is a collaboration between the Royal Marsden Hospital, the University of Cambridge, where Charlotte is based, and the Institute of Cancer Research, which is our Royal Marsden partner academic organisation. So, there we go. Basically, the whole concept of giving radiotherapy to the breast or the chest wall before surgery, until very recently, was a concept that horrified most surgeons. But I will suggest to you that part of that practice had evolved over time, and I think we're beginning to be able to show with these pilot studies that it is perfectly possible to reverse the sequencing of local regional treatment, i.e. surgery and radiotherapy, without any detriment to the patient and potentially some advantages. So, part of the protocol that I'll describe over the next few slides was actually discussed and presented at a workshop in Denmark, and it is published for anyone who wants to have a look at it in more detail in last year in the European Journal of Cancer. And it is exclusively the concepts behind pre-surgical radiotherapy to the breast and where it may contribute. So that's a reference for anyone who wants to look at this in other detail. So what are the advantages to the oncologist and then hopefully the patient to giving the radiotherapy before surgery to the breast? Well, we can actually see the tumour on our radiotherapy planning CT. Otherwise, when we're doing our breast planning after wide local excision, we're having to create a tumour volume. If surgeons put clips in the tumour bed, that's fine. But when I say to my trainees, what does that clip mean? They say, oh, that's part of the tumour bed. I said, no. That's just where the surgeon has been that day. So, and we know that clips migrate. So, actually being able to see the preoperative tumour and plan the radiotherapy is an advantage to us. The second thing that's made the idea of giving radiotherapy before surgery more practical is that as a result of big randomized studies, in particular the START trial, which the Marsden was the lead centre for, we compared 3 weeks radiotherapy with 5 weeks radiotherapy and showed equivalence for local tumour control and also complications. It's not popular in North America, where obviously remuneration is still largely based on number of attendances, but we won't go there. So the other advantage of giving radiotherapy before surgery is that if there are any post-surgical problems, infections, seromas that need repeated aspiration, all that can conspire to delay initiating radiotherapy. And whereas that might not matter over 4 to 6 weeks, we know now that in the immediate post-operative phase, there are lots of growth factors that are released that stimulate cell proliferation. And we've all seen cases of people who are starting to get, especially if they've got heavy lymphatic involvement, are starting to get relapse in the breast before they even get to radiotherapy. The other theoretical advantage of giving radiotherapy before surgery is that if it's in the context of mastectomy and reconstruction, it avoids some of the issues, again, post-operative complications of major reconstruction. So the whole concept of this is that we are giving radiotherapy usually after neoadjuvant chemotherapy has been used to downstage the tumour as much as possible. And we know that most of the women that respond well to neoadjuvant chemotherapy have HER2-positive tumours or triple-negative tumours. So the cases that don't respond very well to neoadjuvant therapy to facilitate breast conservation are the estrogen-positive tumours. And this just shows some data from a colleague in Cambridge, Helena Earle, the Artemis trial, which was attempting in ER-positive, HER2-negative cancers to add in the anti-VEGF antibody bevacizumab, or Avastin it was called, with docetaxel and FEC-based chemotherapy. And really the take-home message from this data was that although the Avastin with this third-generation chemo increased the pathological CR rate in the breast from 17 to 22% approximately, that did not translate into a survival benefit. And the recommendation now is that Avastin or bevacizumab has no role in early breast cancer. So this is just really to show you that ER-positive tumours compared to HER2-positive and triple-negative don't actually downstage very well if they're already at presentation not suitable for the breast conservation approach. In fact, that's the same data, just in a different form, showing that overall ER-positive cancers don't necessarily benefit from that combination of chemotherapy. So being ER-positive may have a longer relapse-free survival for systemic disease, but it is not an advantage in terms of trying to downstage the disease in the breast to facilitate breast-conserving surgery. Okay, so the study design I'm going to describe over the next few slides is called NEO-RT. It's funded in the UK by our biggest breast cancer charity, Breast Cancer Now, and it's a partnership between clinically the Royal Marsden and Cambridge University Hospitals with our academic partner, the Institute of Cancer Research. And the principal endpoints are to see if preoperative radiotherapy can shrink the tumour and make the surgery more conservative. Can we, by taking specimens at baseline of the tumour plus bloods and imaging, predict who is going to respond better than others, so we can modify our practice in the future? And we're also interested in the idea, and this is actually very central to modern immunotherapy concepts, can you actually use the radiotherapy as a DNA damaging agent to cause cell death with the tumour still in situ in the breast, and then release tumour-specific proteins, antigens, that can help stimulate the immune response? So it's really using radiation as an immunogen with the tumour still present in the breast. Okay, so the study design was going to be a single-arm feasibility study in the first instance with just over 40 patients. And our primary endpoint was really to see what percentage of those 43 patients could actually complete the neoadjuvant radiotherapy to the breast and endocrine treatment, then complete to wide local excision as intended. Obviously, the secondary endpoints were us to know, did giving the radiotherapy before breast-conserving surgery increase the complication rate? Did the surgeon end up doing a different type of procedure to the breast as a result of the radiotherapy having created any complications? And obviously, we wanted to correlate the clinical imaging tumour dimensions as assessed by ultrasound, MRI, mammogram, whatever, and then the tumour volume in the pathology. And then finally, of course, we wanted to look at the acute and late radiotherapy issues, as always. So the study group that we've designed essentially excluded HER2-positive patients and grade 3 or triple-negative. So these were ER-positive patients who were unlikely actually to benefit or decline neoadjuvant chemotherapy. The the treatment schedule was 48 grey and 15 fractions, so a fairly accelerated treatment course with an integrated boost, all delivered using IMRT. And the patients all received 20 weeks of endocrine treatment, either letrozole or tamoxifen, depending on their menopausal status. I'm not going to go through this in lots of detail, but essentially, if you follow the pathway left, the timing of assessment, baseline, give radiotherapy and endocrine treatment, proceed to surgery, perioperative follow-up, then long-term follow-up. And it was the usual things you'd expect, patient questionnaires, MRIs baseline. Around the 1st and the 15th fraction of radiotherapy, we were doing bloods and research biopsies of the tumour, and again on in the final week. And then obviously in the perioperative phase, we were again looking at the patient's experience of this sequencing, and longer term we were interested in the patient's evaluation too. So this is the format of the research part of the study. The biological aspects of this are obviously very speculative, but I think probably one of the most interesting concepts is this idea I mentioned as to whether radiotherapy to the tumour while it is still in the patient, can we detect an immunological response? Is radiotherapy cell death actually helping the patient mount a response? But that's all, of course, very speculative. I'm going to skip through that. It's all our whole genome sequencing and our RNA sequencing on the pre and post radiotherapy tumour specimens. We're also looking at our ability to detect circulating tumour DNA during the course of radiotherapy and see whether that correlates ultimately with any kind of measurable responses. And we're also going to be looking at the immune response in the tumour, courtesy of a pathologist in Cambridge called Dr. Ali, using mass cytometry on serial biopsies of the tumour. So that's the more biological elements of it. Obviously imaging pre-treatment and imaging post-radiotherapy, but before excision, with dynamic MRI, looking at the perfusion and vascularity of the tumour. And then we have a different MRI protocol using fluorothymidine and PET, which allows us to look at proliferation in the tumour. Okay, so that's our NEO-RT study, which is still underway between Cambridge and the Marsden, and it's watch this space. The other pilot study we have completed, if we can go on to the next set of slides, please. There we go. Could we load the second present? Yep. The second sequence of slides called Prada.
Yeah, they're about to do that.
Thank you very much. So this is a different No, that's number 3. There's a... Sorry, these might have got slightly out of sequence. Yes, this is the one we want. Okay, so this is a revisit of a presentation we did as a team at the European Breast Cancer Conference only last month. And the study is called Prada, and this is actually looking at giving primary radiotherapy or neoradiotherapy to women who need or want a mastectomy and are suitable for flap-based immediate reconstruction. And it's a surgical feasibility study, and I'm presenting this on behalf of Fiona McNeil, who heads up our Prada research group. So obviously, as surgeons, especially plastic surgeons, one of the big concerns when you've done a major procedure like a DEP reconstruction is flap failure or any kind of soft tissue necrosis. And clearly that represents a major disaster for the patient as well as the clinical team. There's always been concern, of course, that radiotherapy actually given either pre-surgery or post-surgery is going to make the surgeon's job more difficult, vascularity difficult. And the other thing that we notice cosmetically is that if the reconstruction is irradiated, usually 6 months to 12 months later, we probably contribute to contracture of the flap and a significant deterioration in the cosmetic outcome for the patient. And of course, if it's a DIEP, a fat-based autologous flap, you can do symmetrizing procedures on the other breast, but that's complicated for the patient and not ideal. And this shows an example of a patient who has a nice technical DIEP reconstruction, skin-sparing mastectomy, but actually what has happened was that there has been shrinkage of the flap as a result of radiotherapy. You can still see the lines. Okay, let me go back here. So the usual sequence in most departments worldwide for someone who needs, for oncological reasons, a mastectomy is the surgery is performed first, then we give radiotherapy based on the oncological requirement to the chest wall after surgery when it's all healed. And then sometime down the line, usually no earlier than 6 months after radiotherapy is completed, the patient will have a planned DIEP reconstruction if they have enough tissue. So that's probably what still happens around the world still. And it's the other alternative is, of course, that the patient has their mastectomy because the tumour size hasn't reduced enough with any neoadjuvant approach to allow breast conservation. They get an immediate reconstruction at the time of their mastectomy, and when that's healed up, we give radiotherapy as required by the oncological criteria. And when you start getting these flap problems, there's a varying need for salvage surgery to try and improve or optimize the health and cosmesis of the flap. So it's a lose-lose situation if it goes wrong for the patient and the plastic surgical team. So we postulated the scenario that we could actually give neoadjuvant radiotherapy up front in a patient who was going to need a mastectomy rather than breast conservation, and that the reconstruction would proceed at an interval of a couple of weeks after radiotherapy was completed. So the first two are what I described on the other slides. So this is the design of Prada. So we're giving radiotherapy to the intact breast and chest wall, and then proceeding some 2 weeks later to mastectomy, usually skin-sparing mastectomy, and DIEP-type reconstruction. So when this first started being discussed, there was a lot of horror at the MARSDEN. One of our surgeons wanted to implement it as what we call a service evaluation, not a research protocol. And this rang warning bells everywhere, and including with me. I was panicking at the idea of having to give radiotherapy, and then a plastic surgeon phoned me up 3 or 4 weeks later and say, "My flap has failed because of your treatment." So we decided it had to be a formal research study, because you could imagine flap failures now are quite rare, and if we'd given radiotherapy in a sort of experimental format, it was going to be a disaster if there were any problems. And of course, the time scale in all this is quite important oncologically. With this kind of sequence of events, some of our patients are taking up to 3 years to get to the reconstructive part of their surgery or the cosmetic salvage surgery. With this sequence, adding in the neoadjuvant chemotherapy, then the radiotherapy over 3 weeks, then proceeding 2 weeks later to the DIEP, typically we were talking about taking over 2 years off the sequencing of this patient's pathway. So quite considerable. So the considerations in this were really, we didn't think we were going to necessarily improve tumour outcomes. This was about long-term cosmetic and aesthetic outcomes for the patient, because it was going to avoid delays to radiotherapy if the reconstruction had complications. And we also thought, and I think this is the case, that we would probably actually increase immediate reconstruction rates. A lot of women who have mastectomy and are told they have to wait for 6 months to a year after their radiotherapy to have an attempt at reconstruction, they never come back. Okay, you could say that's their choice, but actually a lot of women cope in the post-mastectomy situation by really just dealing with a prosthesis and denial, and many of them have been so unwell during their neoadjuvant chemotherapy, they just can't face the idea 6 months, 9 months, a year down the line of committing to a major procedure like an autologous flap. So we know we've been losing some of these patients out of the completion of the whole cycle. So we thought this approach, if they were happy, would actually mean that they did get an immediate reconstruction. So that was one of our considerations. And obviously we were interested in this idea that we would reduce the number of procedures, trying to tidy up irradiated flaps that had become not satisfactory. So you could say, well, okay, if this is about cosmesis and minimizing the whole treatment package, is it oncologically safe? Well, there isn't any randomized data yet to answer that question, but I would say to you that we have been wedded to the idea of surgery always predating the radiotherapy as a historical thing. It's what we've done for decades and it's what we feel comfortable with. So this potentially was quite a departure in clinical practice. So we had some evidence obviously from other tumour types. Rectal cancer patients typically have been having drugs and neoadjuvant radiotherapy to facilitate or reduce the extent of surgery for locally advanced rectal cancers. So there is a bit of a conceptual background to this. Okay. And if you look, when we looked at any data available before we started off in this study, it was quite limited. There are some very small publications going back into the early 2000s of radiotherapy given before a range of procedures, wide local excision, mastectomy, skin-sparing mastectomy and DIEP flaps, which showed actually either no or very low necrosis rates, if that was the end point. One of the biggest series in recent times, Caroline Baker, who is a consultant in Melbourne, she worked with us surgically for a while at the MARSDEN, had a poster at the San Antonio Breast Cancer Conference based on a series of 82 patients in her centre at Melbourne who had a mastectomy. 72 of the 82 had a DIEP flap as the reconstructive procedure. They had had 50 Gray in 28 fractions preoperatively. In that series, there was a 5% breast envelope necrosis rate. So that's obviously needs to be watched. So the study design was basically, can we give radiotherapy before a mastectomy with the intention of going on to immediate DIEP reconstruction? And it was designed to be a non-randomized study, so we could actually recruit across 2 sites, and the 2 sites we've been conducting this pilot has been the Marsden. I think we've treated 23 of the patients, and our colleagues at Charing Cross Hospital just down the road in London. And the objectives of this study have been to assess really any technical difficulties at the time of mastectomy and in particular the microvascular anastomosis needed for the DIEP, to establish in the immediate post-op phase whether any surgical complications were increased or acceptable and manageable. And then really our challenge was to show with this approach, does it make any difference to the cosmetic outcome for the patient? Because that's the primary objective. So the endpoint we argued over, but we decided we would regard the presence of an open wound in the DIEP at 4 weeks after surgery of more than 1 centimetre that needed addressing. So it was quite an arbitrary and perhaps a gentle criteria of surgical healing after preoperative radiotherapy. Obviously, an important part of this has been trying to quantify the cosmetic outcome, and one of our surgeons at the Sutton branch of the hospital, Jenny Rusby, has been involved in doing this. We have this device called a Vectra 3D surface imaging camera, which looks at the 3D outcomes at baseline, 3 months after surgery, and 12 months. We're also using aplanation tonometry at the same time intervals to look at, if you like, the elasticity and softness of the DIEP reconstruction. And then lastly, but probably more importantly, because this is about improvement in patient outcomes, we have a dedicated questionnaire that the patients all fill in at baseline 3 and 12 months to do with their satisfaction with their breast reconstruction and their other psychological things. Okay. The real exclusion criteria of this study was where it was decided that we could not evaluate from the preoperative imaging, etc., exactly what the radiotherapy target was going to be. In other words, were there uncertainties whether it was safe to just give radiotherapy to the breast and chest wall, or did the whole nodal basin require radiotherapy too? And obviously, anyone who had serious chemotherapy problems that were going to interrupt our sequencing were excluded. So that's the protocol. 5 months of neoadjuvant chemotherapy, a 3 to 4 week interval to recover from the chemo, normally blood counts. We proceed to radiotherapy, and then at any time between 2 and 6 weeks, the surgeon could proceed to mastectomy with or without surgery to the axilla and the DIEP reconstruction. Okay, so that's the timescale. So far we've treated in total 33 patients between January 16 and January 18. The pilot study is now closed while we're deciding what the design of the next phase will be. Obviously, you can see there women in their late 40s on the whole, but we've treated people from early 30s up to 62. As you might imagine, the BMI is fairly high because of the need to have enough fat at the donor site, but we have actually had patients with BMI as low as 19 who have been suitable for DIEP. And quite a number of patients, 24 out of the 33, were node positive, which creates some challenges for deciding whether all the nodes should be irradiated as part of the reconstruction. So, as you can imagine, third-generation chemotherapy, anti-HER2 therapy as required, and this is we were permissive about the radiation fractionation. In the UK now, our standard fractionation, almost all instances, is 40 gray and 15 fractions as per the START study. We also allowed the 16 fraction regime, which is Tim Whelan's study, which is probably biologically about 10% hotter and nearest to the 50 and 25 gray that many other people have more experience of. This slide is just really to show you that there was not agreement about what the radiotherapy target in the preoperative setting should be, and whether or not this makes a difference to the oncological outcomes would have to be evaluated in a prospective randomized study, I think. But most patients had the pre-mastectomy breast and the level 3-4 lymph nodes treated. Only 2 had the breast only with no nodal radiation. 4 had the whole nodal basin as well as the breast, and about 8 had the IMC treated too. So the variable at this point, giving pre-operative radiotherapy, is the radiation oncologist agreeing what actually is the target for therapy. And I think we have to think about this quite carefully in the future. But the important thing is nobody had major toxicities. It's what you'd expect, either no reaction or grade 1 or grade 2 in the run-up to the DIEP. With these shorter fractionation schedules, the skin starts to proliferate again quite quickly, and we rarely see grade 3 reactions anymore. Just finally accelerating here a bit, this shows the time course in our treatment. So the mean time to diagnosis to the end of this whole sequence, that includes diagnosis, neoadjuvant chemotherapy, preoperative radiotherapy, and reconstruction, was on average 7.5 months. So considerably longer than that first slide I showed you, where patients get delayed reconstruction packages. In terms of length of stay, the average stay recovering from the DIEP flap was 5 days, a few a little bit longer. It appeared that giving preoperative radiotherapy, according to our surgeons, they were not seeing the procedure for their DIEP taking any longer than their historical experience, so we weren't making the acute operative pathway more difficult for them. And in terms of the complications, we looked at the immediate complications. No patients had an unplanned return to theatre. We've had no instances of flap failure, which is great relief to everyone concerned. Less than 3% had an open wound at the 4 weeks evaluation point. A small number of patients had some detectable fat necrosis, but not flap necrosis. That's the important thing. And only a small number required antibiotics. So really a pretty uncomplicated pathway for this 33 patients. This shows a typical example, a lady who had a locally advanced cancer, clinically 5 centimeters grade 3, positive axilla, anti-HER2 therapy, third-generation chemotherapy. Disappointingly didn't actually respond as well, so she wasn't heading for a path CR, which was disappointing. So the decision was to proceed to skin-sparing mastectomy, but sacrifice the nipple areola complex. So we gave her radiotherapy to the breast, not the axilla, the level 3-4 nodes, and the plan was for the surgeon to dissect the axilla at the time. And you can see this patient actually had almost no response to neoadjuvant therapy and anti-HER2 therapy, which is very, very disappointing. And 7 of the 29 nodes removed in the dissection were still positive. So in hindsight, I'm very glad that we decided we were going to include the level 3-4 and the internal mammary chain for this patient. But I'm going to stop in a moment. All this study has been paralleled by a translational research arm, which is in collaboration with my colleague at the Sutton branch of the Marsden, Navita Samaya, and there's both an imaging and a blood and tumour-based sampling to look at any tissue or blood predictors of any of the outcomes here. And finally, by way of summary, we've shown that it is feasible to reverse the sequencing of mastectomy reconstruction radiotherapy. We are waiting our 12-month follow-ups, which will be towards the end of this year, and we're trying to design PRADA-2, which is going to be the randomized base of this. And I'd just like to acknowledge collaborators, my group of surgeons at the Marsden, my radiotherapy colleague Anna Kirby, and colleagues at Imperial College, Charing Cross too. And thank you very much for your attention.